Hi everyone, thank you so much for joining our Q&A session today. Finally, we've got Dr. George Mells with us, which is great. Thanks so much for taking time out your clinic to come and spend some time with us, Dr. We really do appreciate it. Just before we get started, just a wee bit of housekeeping as normal, just to remember that these Q&As don't take the place of a consultation with your own clinician. In these sessions, we're aiming to provide general medical information and not medical advice. So because of that, we'll generalise your question to support that. And if you need any more detailed support with a specific issue, please reach out to us on the helpline. As I mentioned, I'll also be recording the session here in Click Meeting so that I can upload it to our YouTube channel. But just for awareness, on the right-hand side where the comments are and where you can put your questions in live for us, that part of the room isn't recorded. So that ensures a private space while we're doing the live Q&A. So we'll make a start on the questions that we've had sent in, but if you have any live questions for us, just pop them here in the chat and I'll keep an eye for those too. So Dr. Mells, the first thing on my list today, and I've timed it in line with a new online monthly group that we're going to start for PBC in men. So what I'd like to do is put a little sort of bite-sized video together to put up on our YouTube channel as well as just about PBC in men. So we do get some questions around, we know the ratio, 9 out of 10 women, 1 out of 10 men, but we often get questions around, is PBC more aggressive in men than women? And are there different things to look out for or be aware of?
Yeah, so the first thing to say is that actually that ratio might not be quite so extreme. There are some newer studies that have come out in the last few years which suggest it might be that the ratio is closer to 5 to 1. So still much more common in women, but maybe it's slightly more common in men than we had appreciated.
Yeah.
That's one of the first things to say. The second is that there are several publications which do suggest that PBC is a bit more aggressive in men. Although it's difficult to be absolutely certain about these things. So the first is that there are studies which suggest that that men with PBC present when they're a bit older age of presentation, that the disease is slightly more advanced when the diagnosis is made. And then there are some more recent publications which suggest that the risk of disease progression might be higher in men. So once the disease has been diagnosed, the risk of progressing to needing a liver transplant or developing liver failure might be higher in men. And there's also a suggestion that the risk of liver cancer in people with cirrhosis, that the risk of liver cancer might be higher. But all of the studies are slightly flawed in subtle ways. So we just need to be a little bit careful about all of these things. I mean, it might be, for example, that actually PBC isn't more aggressive in men, but that appears to be more aggressive in men because perhaps health-seeking behaviors are slightly different in men. Or it might be that PBC appears to be more aggressive, but actually it isn't once you've taken other factors into account. So, for example, it might be that that fatty liver disease was slightly higher in the men that were studied, or that diabetes was slightly higher in the men that were included, or that rates of smoking were slightly higher in the men who were studied. And I don't think any of the studies so far really account for those potential confounding factors very well. But it may still be the case that PBC is more aggressive in men. Even if that is the case, though, the liver tests on treatment are going to be a stronger predictor of the outcome than the biological sex of the patient. And that means that even if PBC is more aggressive in men, that we don't really need to make any changes to the basic approach to the treatment of PBC. We can still be primarily guided by the liver tests and the other markers of disease stage that we use to work out what sort of treatment people need, because those are far stronger predictors, if you see what I mean.
Yeah.
So I would suggest that that we don't really know. Possibly, but we don't really know for sure. In a sense, though, from a practical perspective, it doesn't matter, because determining management based on the liver tests and the stage of disease using, for example, a FibroScan, this will still be valid.
Great, thank you. And just to mention, we will be putting some information out on our socials, but we're starting a new monthly online meeting for PBC and men, so an opportunity for men to come together and talk about that. And that'll be on the last Wednesday of every month at 7 p.m, and we're starting that on the 30th of July. So there'll be some more information on our socials about that as well. Something else that we get questions around is, and just to say, could we have a wee talk about recurrence of PBC post-transplant? So we get some questions around the likelihood of recurrence, what to expect post-transplant in terms of your PBC monitoring, and what preventative measures can be taken.
Well, depending on which series you look at, recurrence of PBC after transplant is probably quite common. So maybe even up to 50% of people will have recurrent PBC. But it sort of depends a little bit on at what time after the transplant you're looking. Very few people will have recurrent PBC if you look a year after the transplant. The figure of 50% actually represents a cohort of patients up to 25 years after the transplant. Mm-hmm. So it does recur at a sort of steady pace, and it probably recurs in up to half of people, but it doesn't happen all that quickly. That's not necessarily worrying though, because not that many people who have a transplant for PBC will lose their liver transplant because of recurrent PBC. In fact, loss of the liver transplant because of recurrent PBC is reasonably rare. Mm-hmm. But that doesn't mean that we shouldn't take efforts to try and reduce that risk if we can. And it does look as though actually routine treatment with ursodeoxycholic acid after transplant for PBC reduces the risk quite substantially, actually. It can reduce the risk by 2/3, it would appear. Which is obviously a good thing. And most people who've had a transplant for PBC, of course, will be very used to taking ursodeoxycholic acid. They'll know that it's a very well-tolerated medication. So to simply continue taking it is probably not particularly arduous for the patient. And that does seem to work. The other thing that seems to be applicable in people who develop recurrent PBC are the prognostic scores that were developed for people who in the non-transplant population. So things like the GLOBE score and the UK PBC risk score, which predict outcome from PBC in the non-transplant population. Those scores appear to be applicable to people who've had transplants for PBC. So they'll give you they allow you to work out the likelihood of the graft coming to harm because of recurrent PBC. And that's quite useful because of course these days we have second line treatments that we can also offer. Mm-hmm. So if on the basis of those scoring systems you estimate that the person might have aggressive, so to speak, recurrent PBC, then those are the sorts of people who could be offered second line treatment, and that will slow down the rate of progression of the recurrent PBC. Yeah. And those second-line treatments would be the ones that everyone knows about from previous discussions, things like obeticholic acid, bezafibrate. We don't yet know about elafibranor and seladelpar in this context, but there's no particular reason to believe that if obeticholic acid and bezafibrate are effective in the post-transplant population, that seladelpar and elafibranor won't be. So any of those second-line agents will probably be effective current PBC. The only caveat to all of that is that there are other conditions in people who've had a transplant for PBC that can affect the blood tests. So if there is a question about second-line treatment for people with recurrent PBC, it is possible that the clinician will ask the patient to have a liver biopsy just to be absolutely certain that they're treating the right thing. Mm-hmm. If that makes sense.
Yeah, no, that's great. And it's reassuring to know that the opportunity for the second line treatments is available to post-transplant patients as well, because initially when the new treatments are released, there's not a lot of evidence around it being used post-transplant. And I think then the automatic assumption is that it can't be used. So it's good to know that there's movement there in terms of that being available, which is great.
Well, there's certainly evidence, there's evidence in the literature indicating that obeticholic acid and fibrates are safe in the post-transplant population. And as I say, it would be very surprising if the same evidence didn't emerge for the newer drugs, elafibranor and seladelpar.
That's great, thank you. We've got a patient who's newly diagnosed, found out through a routine health check. They've had an ultrasound, which the consultant said was fine, and they're now taking their urso daily. The question is that they've worn a Fitbit watch for a few years, and I've always noticed that her heart rate variability is extremely low. She accepts that these things aren't great for measuring such things, but wondered if this is a thing in PBC where the heart rate would be lower. Just something that she's noticed.
Yeah, I had to look this one up actually, because I wasn't entirely sure. The first thing to say actually is that the wearable technology actually probably give us a reasonable estimate, maybe not for comparing to other people, but for comparing changes within yourself. So you know, it's probably a perfectly reasonable measurement. The second thing I found though was that that there's conflicting evidence. So there are some older studies. There was one study from 2006, actually from Newcastle, which suggested that heart rate variability is associated with PBC, and that people with PBC have lower heart rate variability. So that would fit with this this individual's experience. But then I found some more recent studies suggesting the contrary, that heart rate variability was not associated with PBC. So I'm not exactly sure which is true. It seems not unlikely that PBC would affect heart rate variability, because there is plenty of evidence to suggest that PBC, particularly in people with fatigue, affects the autonomic nervous system. And the autonomic nervous system is one of the determinants of heart rate variability. So it does seem likely that PBC would affect it. And perhaps it was just that those two different studies included slightly different patients. Perhaps there were more patients with fatigue in the earlier study and fewer patients with fatigue in the latter one. Second thing to say though, or third thing I suppose, is that heart rate variability is influenced by numerous other factors. And I guess that's what we don't know in this particular case. Influenced by age, influenced by physical fitness, influenced by mental health, influenced by other conditions such as diabetes, influenced by medications, medications that slow the heart rate, for example, things like beta blockers. So there are many other factors that could potentially affect the heart rate variability in this case. But I think it's probably reasonable to say that PBC is one of the factors that could influence it.
Well, that's really interesting, thank you. This question has been asked before, but I know that it does worry some patients, so I've included it again in for today. I've since been diagnosed a year, been losing a lot of my hair. Is this common? Is it a side effect of URSO or of PBC, and does it grow back?
Yes, well, so from my experience in the clinic, I'd say that it's not common, but it's not uncommon. So if you see what I mean. And again, it's difficult to know exactly what might be affecting thinning of the hair in this case. PBC probably can. There does seem to be an association between PBC and thinning of hair. Thinning of hair is probably a side effect, also can be a side effect of the ursodeoxycholic acid. So both of those factors can probably influence it. But then again, there are many other factors that can influence hair growth and thinning of hair. The general physical fitness of the individual, the person's mental health again can influence thinning of hair. Other conditions such as hypothyroidism, systemic lupus erythematosus can affect it. The person's weight, the person's diet, the person's age, whether they're premenopausal or postmenopausal, and so on. So I think there's many factors that could influence hair growth and thinning of hair in this case. And I guess to try and cover all of those individual factors, this person will probably need to speak with either their GP or their liver doctor to see what the most likely explanation is. And if there's no obvious explanation and the hair and the thinning of hair is really substantial, then potentially get a referral to a dermatologist.
That's great, thank you. Question from a newly diagnosed patient asking, what would be your tips for a newly diagnosed patient thinking about tests, monitoring, and what to expect?
Well, at diagnosis, most patients will obviously have had blood tests, because blood tests are very important to make the diagnosis. And in order to conclude that the blood tests look like they do because of PBC and not some other condition, they will probably also have had an ultrasound scan. So I think those will already have been done. The additional test that we would generally offer a newly diagnosed person would be a fibroscan to work out the stage of disease, and a DEXA scan because PBC is associated with slightly more rapid thinning of bones. Once those basic tests are done, the frequency of testing, of repeating those tests, will really be determined by what the first batch of tests showed. So if after a year's worth of treatment, it transpires that this person has very well controlled PBC, which is still very early in stage, then repeat tests might be done very infrequently. So, for example, they might have blood tests just once a year. They might have a fibroscan every 3 years, for example. They might have an ultrasound scan every 5 years, or even less frequently than that. DEXA scans we would generally repeat every 5 years once we've started. Whereas if the PBC is more advanced, then it might be that the blood tests are done every 6 months, even every 3 months. The fibroscan might be every 1 or 2 years, and so on. And if the person has cirrhosis, then they would need a 6-monthly ultrasound scan. And if the initial test suggests that they have cirrhosis with portal hypertension, then they might be offered an endoscopy, a gastroscopy camera test of the stomach, to see whether they have varices. So it'll depend a lot really on the stage of disease and how well controlled the PBC is once you've got them on treatment. But those are the sorts of tests that people might encounter at some frequency or another.
That's great, thank you. Just picking up on what you said there, I just thought it was worth picking up that one of the questions that we've had in the room here. So someone's asked, I have cirrhosis due to PBC, hepatologist now doing ultrasounds every few months rather than fibroscan, not sure why this is. I think you've kind of covered that there. It was maybe just to mention a bit more. But
let's touch on it, because actually that's a very general, that's a question with general implications. So people with cirrhosis, not just caused by PBC, but any form of cirrhosis, have a slightly increased risk of developing liver cancer. It's not really increased high enough for people to be worrying about it, but it is increased high enough that you would want to be doing regular scans so that if it happens, you detect it at an early stage when it's still very small and still extremely treatable, because there are many treatments available for liver cancer. So it is worthwhile picking it up at an early stage and making sure that those treatments will work. Therefore, any patient with cirrhosis, irrespective of the cause, not just PBC, but any other cause as well, will be offered a 6-monthly ultrasound scan. Fibroscans are done for a slightly different reason. So the first reason that we'll do a fibroscan is to work out if the person does indeed have cirrhosis, and that's partly so that we can then offer them these 6-monthly ultrasound scans. The second reason that we might do fibroscans is to work out whether the person is likely to have varices. Varices being swollen veins in the gullet or the stomach. And the reason we do that is twofold. Historically, if a person was likely to have varices, we would then offer them the endoscopy, because with an endoscopy, the camera test, you can actually see the varices. And if you see the varices, then you would say, okay, let's give you some medication to reduce the risk of those varices bleeding. But these days, actually, we think that we can probably guess if a person has varices based on the fibroscan measurement itself. So if the fibroscan measurement is greater than 25, for example, you can be pretty certain that that person has varices. Don't bother with the endoscopy. Just offer them that medication to reduce the risk of bleeding from the varices. But clearly, if that's the reason you're doing the fibroscan, you will need to repeat it occasionally in order to work that out. So it depends on the context, but for the person who's just said that they've been having regular ultrasounds because they have cirrhosis, well, that's good, and that is being done because of that slightly increased risk of liver cancer, so that it can be detected at the earliest possible stage, should it happen.
That's great, thank you. And just while we're on cirrhosis, we've had a question around, once decompensated, what would the criteria be to be considered compensated again? Could you just cover the differences between compensated and decompensated?
Yeah, so in conceptual terms, a person can have cirrhosis, compensated cirrhosis, for many, many years. So anyone who's been told that they have cirrhosis, key thing is don't panic. Doesn't actually matter. Your liver can function extremely well despite cirrhosis. And in some ways, cirrhosis is a more useful term because of that liver cancer thing. It just tells us that it's time to be monitoring slightly more closely for the slight risk of liver cancer. It doesn't tell us that the liver is falling apart. But the key point is that if someone has cirrhosis and their liver is functioning well, it's still doing all the jobs it needs to do, that liver is compensated. A liver, where the person has cirrhosis and that cirrhosis is now advanced enough that the liver is struggling to do what it's meant to do, that is when the person has decompensated cirrhosis. And the features that would generally define decompensated cirrhosis would be jaundice, yellowness of the eyes, or ascites, which is fluid inside the abdomen, encephalopathy, which is confusion, significant confusion caused by liver disease, the buildup of toxins in the bloodstream because of liver disease, or in a person with advanced cirrhosis, bleeding from varices. So those would be the sorts of things that defined decompensated. It is possible in some liver diseases to move from decompensated to compensated. So if with treatment of the liver disease, for example, all of those things disappeared, the jaundice disappeared, the ascites disappeared, the encephalopathy disappeared, and there was no further risk of bleeding from varices, then you could say confidently that this cirrhosis was now compensated again. The liver is now doing what it's meant to do despite scarring. But that doesn't generally happen in PBC, actually. The treatments we have are very good at preventing cirrhosis and preventing decompensation, but they're not very good at reversing it once it's happened. And actually, we shouldn't really be using drugs like obeticholic acid, elafibranor, or seladelpar in people with decompensated cirrhosis. All of the prescribing literature says that they are contraindicated in that context. So once a person with PBC has decompensated cirrhosis, it seems unlikely that it would recompensate unless there's some other factor involved. And really, it's time to start thinking about liver transplants at that point. It doesn't mean the person is committed to having a liver transplant, but it's certainly time to start thinking about it.
Okay, thank you. Just when we were touching on tests earlier on as well, there's a question about when you were talking about DEXA scans. Patient has asked for a DEXA scan, but this hasn't been offered. 53-year-old woman, stage 3. Sister has osteoporosis. How can I tackle that? I've not been offered a DEXA scan.
Yeah, well, DEXA scan isn't the only way of measuring bone health, actually. I mean, there is a scoring system called the FRAX score, which can be done without a DEXA scan. And that FRAX score estimates the likelihood of having thinning of bones, osteoporosis. And usually the next step is it usually tells you whether a DEXA scan is indicated to confirm that observation. And then based on the DEXA scan, you can recalculate the FRAX score to estimate the risk of fracture and decide whether treatment is needed. So it might be, I don't know, but it might be that this person's physician has calculated a FRAX score or an equivalent score to work out the likelihood of osteoporosis. It might be that the calculation is low, and that for that reason that there is no need for a DEXA scan because the likelihood of osteoporosis and osteoporotic fracture is so low. Therefore, I think the best thing to do is to simply ask, actually, at the next consultation. Bone density changes very, very slowly, so waiting for the next consultation is probably fine, actually. But if there's any particular concern, writing to the consultant via his or her secretary would also be fine.
Great, thank you. Another question about a test, actually. Professor Jones previously mentioned Lipoprotein X as a useful blood test regarding the heart and the amount of cholesterol versus cholesterol from PBC. They've tried to no avail to see when where this test can be performed. Could we ask at our next session how to get this done, please? I take it again, is that something the GP could arrange?
Well, it's not a routine test, actually. Right. Most hospitals, most GPs and most hospitals will not actually be able to offer Lipoprotein X. There is a way of getting around that, though, which is to measure something that is routinely available. Not a common test, but it is available in most hospitals, which is to measure the apolipoprotein B. Essentially, if the cholesterol is high and the apolipoprotein B is low, then that would be an indication that the cholesterol is high because of lipoprotein X, and that person would not really need cholesterol lowering treatment. On the other hand, if the cholesterol was high and the apolipoprotein B was also high, then it is unlikely that the elevated cholesterol is the result of lipoprotein X, and that person should probably be offered cholesterol lowering treatment. So the way round it is to use this other test called the apolipoprotein B. The only thing I would say, though, is that is a very uncommon test. I mean, I have never asked for an apolipoprotein B, and if I got a lipid measurement which included the apolipoprotein B, I probably wouldn't really know how to interpret it. So realistically, if this question has come up and there is real doubt about whether the cholesterol should or should not be treated, then I think realistically advice will need to be sought from a person who specializes in lipid management. So that would be usually a consultant lipidologist in some centers, or the local clinical biochemist or chemical pathologist in other hospitals. There will be someone who specializes in it, but their advice will be needed under these circumstances, because it's a very uncommon test for us to ask for, and most of us simply won't know how to interpret it.
That's great, thank you. I just wanted to go back to a question that we have in the room here. So around the question that we'd had about cirrhosis, any tips on how best to communicate with doctors that have cirrhosis due to PBC? That's at appointments about other health issues. Keen to keep it simple and clear, bearing in mind many don't know what PBC is.
I'm not sure I completely understand the question, actually. I mean, I think simply saying that you have cirrhosis because of primary biliary cholangitis should be enough. And if it is relevant and the doctor doesn't know what cirrhosis means or what PBC means, then because it is relevant, then advice should be sought from the gastroenterology or the hepatology team. So an example there would be, let's imagine that a person has cirrhosis because of PBC and they need abdominal surgery for some reason, cholecystectomy, appendicectomy, common abdominal surgery. We couldn't realistically expect the consultant surgeon to know all that much about cirrhosis or PBC. That would be unfair, because they need to know about doing operations. But very clearly, cirrhosis could influence the outcomes from the surgery. So we would expect that surgeon would get in touch with the gastroenterologist or the hepatologist just to check whether the person was safe to have that surgery. I think that would be the sort of pathway there. Likewise, it might be that a person needs a hip replacement, and the orthopedic surgeon doesn't know much about cirrhosis or PBC. We wouldn't expect the orthopedic surgeon to know much about cirrhosis or PBC, but we would expect that the orthopedic surgeon would recognize that can influence the outcomes from the hip operation, and once again would drop a line to the local gastroenterologist or hepatologist to check that it is safe to proceed. So that and there, I don't think that a huge amount of information is needed. Actually, simply saying I have cirrhosis caused by PBC is probably enough. But I might be not getting the full understanding of the question.
That's what I took from it as well, to be fair. Yeah, no, she's saying that's helpful. Thank you for that. I'm just going to go back. There's another question in the chat as well from someone asking, I've started getting a lot of cramps all over my body in the last year. Is this common in PBC patients?
I wouldn't say it's common in PBC specifically, but it is something that we hear quite a lot of from people with liver disease, in particular, slightly more advanced liver disease. So I don't know whether this person has cirrhosis or not. If they do, then actually cramps is not unusual. Quite common, I hear people complaining about cramps when they've got cirrhosis. Early PBC, I wouldn't generally associate with cramps specifically, but muscle aches and pains, not cramp type muscle aches and pains, simply general myalgia and arthralgia, joint aches and pains. This is incredibly common in people with PBC. At every stage of disease. So I suppose it depends a little bit on what the person means by cramping, and also depends a little bit on what the stage of their disease is.
Okay, thank you. Back to our question list. So we've got a patient asking, I wondered if you had any information on the pluses or minuses of taking creatine supplement. It's popular with postmenopausal women for a number of things, but very wishy-washy advice online in terms of dangers for people with liver disease.
Yeah. So I agree that the information is wishy-washy. Unfortunately, the information is wishy-washy for the physicians as well as the patients. So I don't know that I can give really clear-cut advice on whether it is safe or not. That said, I would also say that I don't think that there is particularly strong information about whether it is helpful in PBC. So I wouldn't generally recommend creatine. I wouldn't necessarily ask people to not take it unless they had advanced liver disease. If they had advanced liver disease, then we often just take the slightly safer option of trying to avoid whatever you can avoid. Even try and avoid medications you don't need to take. So I'm sorry that it's not particularly clear-cut advice, but I agree with the person who sent in the question. The information simply isn't there.
Yeah, it's difficult for us to say yes, it's okay or not. Yeah, no, I totally appreciate that. Just when we were chatting there about this, the cramps, we've got an update in the chat there just to say, just waiting to hear if I have cirrhosis, but likely early stages. So what you were saying potentially makes sense then. If there's early stages of cirrhosis, and it would be cramps.
Yeah, so yeah, potentially. I mean, if the person means early stage of cirrhosis, then yes, that might explain cramping. If they mean early stage disease as a non-cirrhotic, then I wouldn't generally associate cramping with the PBC. But as I said before, it's very common for people to have just generalized aching, the sort of aching that people experience if they've got the flu, for example. That's very common in PBC, irrespective of the stage of disease.
Great, thank you. We have a question around radiation treatment. When I started radiation treatment for cancer, I felt the best I had for years. I'm presuming it's because the radiation was zapping my autoimmune cells as well as the cancer cells. A couple of months after it finished, my fatigue returned. Just wondering if there is any way to kill the autoimmune cells or suppress them.
Well, at this point in time, no. I suppose the first thing we should say is that it's surprising to hear that the person felt better during radiation therapy, because most people actually feel completely wiped out by radiation therapy. So that's slightly unusual. The second thing is I don't know that we can necessarily be absolutely certain that the reason the person felt better is because the autoimmune cells were being wiped out. Because I don't know that radiation therapy would be able to target autoimmune cells over and above immune cells in general. And then the third thing to say is that actually many immunosuppressive medications have been tried in PBC, and so far they've all failed. So all of the conventional immunosuppressants have been tried. Azathioprine has been tried, methotrexate has been tried, cyclosporin has been tried, and none of those agents appear to work for PBC. And some newer biological medications have also been tried. Abatacept has been tried, for example, and those also appear to give no benefit. So far, we don't yet have an immunosuppressant or an immunomodulatory medication that we can use for PBC. But, you know, one would hope that eventually we'll get there. The treatments, immunosuppressive or immunomodulatory treatments, are increasingly sophisticated. The latest treatments that have been developed are CAR T-cell therapies, where you can essentially train the T-cell to either recognize the autoimmune cell and suppress it. So that, and those will be explored over the next few years, and perhaps that's how we'll eventually get around this lack of ability to control the immune system in PBC. But there are no treatments so far.
That's great, thank you. Is there a link between PBC and low folic acid?
No, no, and low folic acid is generally caused by nutritional issues. So I think the person who's had, firstly, actually, folates can be spuriously low. So a folate measurement which is low once is probably worth repeating. But if it seems genuine, then the person might need to just have a look at their diet, actually, and see whether there's a nutritional explanation. PBC can be associated with some conditions of the bowel which influence the absorption of vitamins. So PBC, for example, could be associated with celiac disease. So if the person appears to be eating a very healthy diet with plenty of vegetables, and the folate is still low, then it might be that the GP should check for celiac disease just to be certain. But it's probably not because of the PBC.
Great, thank you. Another one asking about, is tingling or numbness in the feet, hands, arms or legs a symptom of PBC?
No, it isn't. And actually that person, I think, probably ought to have a chat with their GP just to start looking for other explanations there.
Thank you. Can osteoarthritis cause an increase in ALP?
It shouldn't do. Alkaline phosphatase can be elevated from bone because there are different types of alkaline phosphatase. So there's a liver one, and there's a bone one, and there's an intestinal one, and there's a placental one, and there's a prostate one. So many different types. And if the alkaline phosphatase is elevated, it could in theory be coming from any of those sources. It would not usually, elevated bone alkaline phosphatase would not usually come from osteoarthritis, though. So broken bone could cause it. Vitamin D deficiency causing osteomalacia could cause it. Paget's disease could cause it. Those would be common causes of increased bone alkaline phosphatase, but not osteoarthritis.
Thank you. Someone asking about platelets. They've stayed around 120,000 for 2 years. Could it be because of PBC? Is 120,000 a low reading for platelets? Slightly
low. Depends on how you look at the measurements, but yes, the usual would be a level of around 150 or 160 or above.
Okay.
So 120 slightly low. And yes, it could be caused by the PBC. And the usual mechanism there would be that the PBC has caused portal hypertension. Portal hypertension is usually accompanied by a slightly big spleen. And when the spleen is big, then the platelets, instead of circulating, some of the platelets become sequestered within the spleen. So the platelet count drops. And therefore, the platelet count can be a very useful marker, actually, of how advanced the PBC, or any other liver disease, by the way, is. If the person does not have cirrhosis and does not have any evidence of portal hypertension, then they might want to start looking for some other explanation for a slightly low platelet count. But usually, a low platelet count in somebody with liver disease is usually an indication of the stage of disease.
Thank you. Just to say to the people who have joined us in the room, we're approaching 10 to 3 now, so if you do have any other live questions for us, if you let me know in the chat, I'll pick them up. Our next question on the list is, how does urso work in the treatment of PBC?
We're not 100% sure, actually. We know it does work. There's plenty of evidence to indicate that it does work because it improves the liver blood tests. It slows down histological progression and it improves long-term outcome. but the exact mechanism by which it works is not 100% clear. It might work by changing the composition of the bile. So it might be that in PBC, that the slightly more toxic type of bile acids, the hydrophobic bile acids, increase in concentration and cause harm. And one of the ways that urso might work actually is to dilute those toxic type of bile acids, the hydrophobic ones, and replace them in essence with the slightly friendlier bile acids, the hydrophilic ones. That's one potential action. The other is that it might simply just increase the flow of the bile, the rate of flow of bile. It might increase the amount of bicarbonate in the bile. Bicarbonate is important in bile because the cholangiocytes, the bile duct cells, create a bicarbonate umbrella, a sort of raft of bicarbonate, which helps to protect them from those toxic hydrophobic bile acids. So if ursodeoxycholic acid increases the amount of bicarbonate in bile, then it can support that bicarbonate umbrella, so to speak, and help to protect the cholangiocytes, the bile duct cells. Could be any of those mechanisms, but as I say, we're not 100% certain. Key point is that it does work. Using the measures in front that we have available to us in the clinic, we know that it works.
Mm-hmm. Just looking then at the second line therapies, similar question around how does OCA work, but then how does it work in comparison with the new second line therapies, so seladelpar and elafibranor?
Well, although we don't have a completely clear understanding about why urso is effective, we have a slightly better understanding actually of why, at least in theory, why obeticholic acid and the PPAR agonist, the elafibranor and the seladelpar work. Obeticholic acid is what's known as an FXR agonist, which means that it stimulates or activates a particular receptor inside the liver cell called FXR, the farsinoid X receptor. And FXR is the key protein, the key molecule in bile acid metabolism. If you activate FXR, then you reduce the production of bile acids, but you increase the production of bile. So you end up with more bile containing fewer bile acids, slightly more dilute bile, and that probably protects the cholangiocytes because of what we said a moment ago, that contains these hydrophobic bile acids, which are toxic to cells, toxic to the bile acid cells. So if you're producing more bile and the bile is flowing faster, but it contains less of these toxic substances, these toxic bile acids, then that bile will be friendlier. That protects the cholangiocyte and reduces the amount of inflammation inside the bile duct. That's potentially the mechanism. There might be other mechanisms, but that's thought to be at least one of the important ones. And the newer drugs, the elafibranor and seladelpar, they do something quite similar, but by activating a slightly different molecule. They activate a molecule called PPAR. PPAR is also involved in bile acid metabolism. It also, through a slightly different mechanism, reduces the amount of bile acid being produced. And it also, again, through a slightly different mechanism, increases the rate of flow of bile. So, but the same outcome occurs, that you have more bile containing less bile acid. And that, again, that probably protects the bile duct from toxic injury. Again, we never 100% certain about why things work, and it's slightly more important to simply know that they work. So the same applies, actually. We know that obeticholic acid works because it improves liver blood tests in people who take it, and it's been shown in these large cohort studies to improve outcomes, to reduce the rate of disease progression and the rate of transplantation. And there's and we would, there is evidence to suggest that elafibranor and seladelpar also work because they improve the blood tests of people who are taking them. So I think, although we don't know for sure why they're doing a good job, we do know for sure that they're doing a good job.
Great. We're approaching end of time just now. I would just like to say we've got a couple of Ursel questions. I'll quick fire them for you. They should be quite straightforward. On the wrong dose but biochemistry stable, should it be changed?
Well, depends what you mean by stable, actually. If somebody had perfect liver tests and they were on a lower dose of urso, I probably wouldn't, I wouldn't necessarily push it up. I mean, I might push it up to the optimal dose. But I guess in reality, what would have happened if I was looking after the patient is that they would have been on the optimal dose. I'm not trying to credit, but you know, they would have ended up on the optimal dose from the outset. So we would never have known if a lower dose achieved better biochemistry because they'd already been on the higher dose, if you see what I mean. If I met someone who was on a lower dose and their liver tests were already completely normal, I'm not sure that I would necessarily force them to increase the dose. I might suggest it, but I certainly wouldn't push it because what we're aiming for is normal liver tests. They're already there. On the other hand, if the liver blood tests are okay, but they're not normal, then I would want that person to try a higher dose because, you know, getting them normal is kind of where you want to be, basically.
Next question kind of follows on. Can you alter your own dose using the calculator, or do you need your doctor to okay it first?
I would really, really advise people not to fiddle with their medications, actually. Ursodeoxycholic acid is a well-tolerated drug. It doesn't have very many side effects, but as a general principle, I would say, you know, every drug is... every medication is not something you would ordinarily be putting into your body. And therefore, it's best that the doses are adjusted in consultation with someone who really is familiar with those medications and what they do. So I would encourage this person to just stick with what they're on, but make a note of the fact that they're on a suboptimal dose and make sure that that is discussed at the next appointment.
That's great, and I would echo that in terms of our calculator to be used to check that you're on the correct dose rather than give the dose to yourself. It's to check that you are getting it to speak to your doctor. And very last question I'm going to squeeze in. When starting Urso, is it okay to start taking it slowly and build it up to your full dose?
Yeah, and I must admit, that would be my usual practice, because I find that if you go full whack, people often get a little bit of abdominal discomfort or right tummy and so on with it. Whereas if you introduce it gradually, the bowel seems to get used to it. So that would be my usual approach. Again, though, it's probably best to just make sure that your doctor is aware of what you are or are not doing. So if, for example, they've said start Urso 1,000 milligram a day, but you decide that you want to build it up slowly, to start with 250 milligrams a day and build it up, for example, that's probably going to be okay, but why not just send a message to the consultant and make sure that they're aware, and then they can send a message back saying that sounds absolutely fine.
Rather than just deciding on your own.
Yeah, I think so. And most clinicians, you know, are pretty happy with that sort of conversation. You know, that they wouldn't take that as being a challenge, you know, to their great wisdom. I think that most of them actually get back in touch and say, sounds fine.
Brilliant. That's great. That's us for the day, Dr. Mells. Thank you so much for taking the time to join us. That's been a great session. Thanks to everyone that's joined us in the room as well. And we'll get this session uploaded to our YouTube channel as well.
Super.
So, thank you.
Thanks
See you again soon. Take care. Bye.